it's a controversial topic, and that's why it requires a lot of detail. And I doubt we have a consensus amongst us all across the world. And each shoulder surgeon, you could split them in half in those who believe in arthroplasty in proximal humerus fractures, such as hemiarthroplasty, uh, and those who just prefer a reverse. Uh, that's why the Hemi got a lot of bad flack and bad press uh, because of the published literature as such. But I don't subscribe to that. So I'm going to give you my philosophy on the proximal humerus fractures and hemiarthroplasty. So firstly, we must make a clear distinction between fracture healing on proximal humerus fractures and the restoration of function. And that's not consistent across our patients, even in the best hands. A lot of proximal humerus fracture fixations don't get their perfect function back again. And that must be said, the same must be said about hemiarthroplasty in proximal humerus fracture. And because of the discrepancy in results, hemiarthroplasty has become rapidly unpopular, especially in the European world. So why is that so? The first principle we need to understand is if a surgeon is able to restore the 3D architecture of the proximal humerus, then he's going to give them back the function. A lot of that 3D architecture is related to version and height restoration, and I'll like to speak a little detail on that in the latest part of the slides. But if we can achieve an anatomic tuberosity healing, the greater tuberosity, and largely that is a result of restoration of correct version and correct height, then we are likely to get a good result. A good rehab program is also very important. So you will see that units which have a reputed rehab program tend to do well. We must also remember that there's a clear distinction between treating fresh fractures with hemiarthroplasty and those that have been tried with a conservative program or a failed fixation. And so we're not comparing apples and oranges in that case. Firstly, the hemiarthroplasty that is done for osteoarthritis and those that have been done for fractures is as different as chalk from cheese. In a trauma situation, we don't have landmarks. The biceps is an unreliable landmark. Murchowski's paper gave us a reference of pec major, but again, there are at least 3 papers that said that that's a soft tissue landmark and that's largely variable between patients. Version, most of us were taught that we have to put in a fixed version of 20 to 30 degrees, but that may not be correct. Those of us who use a arthroplasty should be aware that our prosthesis should have a restoration of posterior and lateral offset, which is part of the natural anatomy. And if your prosthesis doesn't have a posterior offset and lateral offset option, then we are unlikely to restore 3D anatomy. In fractures, it is often very difficult to evaluate a presence of axial nerve palsy and a rotator cuff status, which will also impact the outcome of these patients. However, the biggest bugbears of hemiarthroplasty have been 11% GT complications, 7% proximal migrations later. Glenoid erosion, if you look at this patient on the top, this is one of our patients whom we've done a hemiarthroplasty 9 years back. And you can see that there's a significant medial migration here, all the way down to the coracoid here. He has full function, and so it's very difficult for me to tell him to come in for a revision, though we are monitoring him closely. And whereas this is a 65-year-old lady who's had it 13 years done, and she has had no medial migration at all. So we don't quite understand this as yet, but that seems to be a consistent feature in the late hemiarthroplasties. But the lock plate or the Phellos plate is not without fault. The percentage of complications are rather high, 45% complication rate, 25% reoperations. But the most sad part of the lock plate is the 22% screw penetration, of which 14% were on day 1 times 0, and 8% happened later on. So this is not without fault. I think it was Pascal Boileau's paper which spoiled everything, where he showed a 23% GT detachment, and even some of them, even after they were correctly positioned. But one must understand that few of these papers about GT disruption were about elderly patients. And so you may not extrapolate the same to the younger patients, because that would be different. I think Pascal's one conclusion was very pertinent, that retroversion is very individual and not a fixed 20 degrees as Neer advised. One must be very careful of axillary nerve, and I'm very concerned about the mid-deltoid split approach. And if those of you who have not read the Westphal paper, Jan 2017, should go and read that, because they had a 10% complication of axillary nerve in all their deltoid split fractures. These are various scenarios that can happen where in the top side you see the GT is too proud, and that's not going to have a good function at all. The second one, the GT was in position, underwent osteolysis later on. And the third one is pretty much what we would like to have into our patient, where after repairing the GT, it should look like it belonged there as a snug fit. One knows that if the version is incorrect, then even with the first internal rotation, the GT will just split off and come off, and that will lead to a disaster, because without the GT healing, the results are pretty much all or none. There are lots of complex devices to allow us to judge the height of the prosthesis. It becomes tedious, and I don't believe in using them. I use a dedicated fracture stem. As you can see here, there are markings here. So I would do a trial reduction and ensure that on my trial, everything sits down as a snug fit. I can do a parachute closure, and my ream has the same marking as my final prosthesis, which has a honeycomb appearance with a HA coat, which is only proximal HA coat, so that there's a friction fit between the GT, which wants to stay in there. And so never use a smooth stem that you would use for osteoarthritis for a trauma situation. Uh, Once I've finished my proximal humerus hemiarthroplasty, I want my entire parachute to close in an anatomical fashion in a tensionless manner, and I would do a rotational movement. This is one of the patients who's 5 years after a hemiarthroplasty. It's almost a full function. So unfortunately, we don't tend to get this in all of the patients, but we must endeavor to try. I think a lot of my practice changed after reading this Mark Frankel paper on the cerclage wiring, and I combined that with a Nice knot, and we published a paper on the Nice knot being a superior knot than the standard surgical knot. Before we dwell on the literature on proximal humerus hemiarthroplasty, I would suggest that when there's an in-between case where young patient, you would still like to preserve the head and reluctant to do a hemiarthroplasty, this is a Bilboquet prosthesis, which is now called as a Just Unique, and helps us retain the normal anatomy and can be used instead of replacing the head. But you need to have very clear indications of when to use this. And I have this on the side table all the time. This is one of our patients. This is 1 year post-op, and then this one on the top is the same lady 2 years post-op, and you can see she has had an excellent result with the Just Unique. And so we've managed to preserve her head. She's 60, she's on the verge. I could have done a hemiarthroplasty, but here we have maintained her normal anatomy, and we still have not burnt any bridges for a future correction if that was required. Now, this was our paper, which was published in 2011. We had a reasonable result. Our age group was fairly young. Average age was 56. But if you look at Namdari's paper, who compared the hemiarthroplasties with reverse shoulder replacement, there's hardly any difference between them if you took the young patients on hemiarthroplasty, and they had a higher complication in the reverse arthroplasty group. Of course, the reverse is far better, superior, has a faultless results. The movements are better, but it's a big job to do on a young patient. There are higher costs and infection rates are higher. However, both the hemi and the reverse would have results drop after 10 years in terms of clinical functions. Before I finish off, I would like to touch base with the fact that if patients are above 75, I think we have a fair consensus on this, that we would prefer to do a reverse shoulder replacement in 80 years old patients because of the osteoporosis and the lack of rotator cuff support on those patients. And they tend to do so well because we don't want to offer a revision surgery at that age, and all we want to do is a function restoration. The rotations are not as impressive as hemiarthroplasty, but their forward flexion abduction tends to be very impressive. So in conclusion, you need to choose between the whole basket of options between plate fixation, a Just Unique, a hemi, or a reverse. There is no one good answer. The biggest challenge is in those gray areas where you have a 4-part fracture and a young patient who's 50 and you're torn between a fixation and a hemi. You could then jump into a just unique without compromising the head of the humerus. So finally, in conclusion, we must not forget the conservative option, because based on the Prophet study, we know that that has a reasonable good result, which is comparative to some of the fixation results. Anybody who can get the GT in position and get it to heal will win, whether it's a hemiarthroplasty or a reverse shoulder. The biggest dilemma is the young patient with complex fracture dislocation, 4-part. One must always choose a trauma prosthesis when you're doing a hemiarthroplasty, but we are a great believer in native restoration of function, in native restoration of the version, because on our anatomical cadaveric study, our cadavers had retroversion varying from 15 degrees to 50 degrees. And I'm loath to put in a fixed 20, 30 degree because that would go wrong in half the patients. And we believe we can restore function because we use a native version on most of our patients. Certainly in above 70 patients, 70-year patients, I would definitely try to prefer a reverse shoulder arthroplasty rather than a hemiarthroplasty in those patients. Thank you very much for your attention.